Ladies and gentlemen, welcome this vibrant gathering. Now I would like to invite our next speaker, one of the greatest functional neurosurgeon who is working in NINS, help the hopeless people who are refractory to multiple anti-seizure medication. Dr. Harun Sir, he is working as an associate professor, neurosurgery. Please, sir, come to the dais. He will talk about epilepsy surgery, substrate, and strategy.
Assalamu alaikum. Good noon, Honorable Chairperson, respected panel of experts, and my dear colleague. I am Dr. Harun Sir, working in the Functional Neurosurgery Department. So, you know, without necklace, someone looks pretty, but if she wear necklace, she looks complete, gorgeous. So I would like thank you, our honorable director and co-director, sir, to introducing the functional neurosurgery department in neurosurgery wing, as this functional neurosurgery is the necklace of neurosurgery part. Thank you, sir. So next few minutes I will talk about what's the basic mechanism behind this resistance, cases, and if we get any drug-resistant epileptic patient, how we go for pre-surgical evaluation, and what are the signs or symptoms we look for in semiology that gives us confidence that patient will get benefited from surgery, and who are the ideal surgical candidate, and is the surgery safe? So when we introduce first anti-epileptic drug, the 47% of the patient, they become seizure free. Those who do not respond, we add second one. Now this time only 13% of the patient respond. Not this time again 47%. So there's definitely some region is there, and rest of the 40% actually we may add some of the drug. There is a little response. So we should bring this patient for pre-surgical evaluations. So you know the duration between when the patient first come to the epileptic clinic and they went for pre-surgical evaluation, it takes almost 18 years to come for pre-surgical evaluation. But from the very beginning, we can understand some of the patients may be resistant. If we choose one appropriate drug for any epileptic patient and it is not responding well, then we should might consider this patient may be a resistant case. Or if we find any case who are not receiving treatment after having several episodes of seizure for several months or years, then this case might be a resistant case. So from the very beginning, you can understand you can select it, or you can have some guess that the patient might be a resistant case. So where's the structural lesion is there? Where's the reason? Where's the mechanism behind this? Those who are not responding, those who are resistant, there is some axonal changes there, and the changes in the synaptic vesicles as well, and gliosis is there. And because seizure goes on, there is an increase in networking. So in resistant cases, the network increases in time. So this is a boy of 12 years who started having seizure when at the age of 1.5 years. Initially he had seizure of right-sided clonic movement followed by deviation of the eye to the right side. And after several years, the seizure changes, and only there is epileptic spasm is there. And what you are seeing, there is a portwine stent on the left side of the face, and there is a leptomeningeal angiomatosis in the occipital lobe. So this is the only visible part in the MRI. But if you see the PET, what you are seeing, the whole temporal lobe is hypometabolism is there. So there is the abnormal neuron extend from the occipital to the temporal side, which is evident by the epileptiform discharge by the temporal and the occipital chain. So the boy born with this disease, that's because it is not responsive, it is resistant, its network increases in time. So my first take-home message is that epilepsy is a disease of abnormal neural network, and this network extended beyond the radiological lesion if it is resistant, and the size increases in time. So it's not static, it is dynamic. So after getting one patient in our pre-surgical evaluation, we sit together with the neurologist, with neuroradiologist, neuropsychiatrist. We're trying to localize or lateralize the lesion. So being an epileptic surgeon, I must understand that the lesion is producing this seizure. So we have to very carefully evaluate the semiology. But most of the time when we get the patient, visually they describe their signs of ictal phase and post-ictal phases. And they actually miss their ictal onset symptoms. That is corresponds to the aura. So this part only patient can experience. And there is some aura is there, there's very much characteristics. In the temporal lobe, it is epigastric resic sensation. There may be auditory aura. And I will show you one important aura that we have. See, this patient admitted in our ward for prolonged recording. But what we're seeing here, we failed to find any kind of epileptiform discharge during admission. But the sign of video is this: there is the ictal split is there, and patient is intensely anxious. So look, his face and fear is there. He wants to go out, and he come back again to his home. And what you're seeing, there is a hyperintense lesion is there in the left hippocampus. And again, there is some sign is there in the semiology, some manifestation, some feature is there that actually help us to localize the lesion. The first one is the automatism. That is very much characteristic in the temporal lobe epilepsy. And usually it is the unilateral. So if one patient have unilateral automatism, suppose in the left side, so probably the lesion in the left temporal. And if the patient in the frontal side, if the patients in the patients of head version, usually contralateral side of the lesion. So if a patient versions to the right, so lesion may be left frontal. And another important sign, that is figure of 4, where one hand is flexed and another hand is extended. So lesion is the contralateral side of the extended hand. This is one of our patients that we admitted for surgery. What we are observing, it is at night, there should be light during recording. But what we are observing, there is a abnormal movement in the right hand, that is right hand automatism, and also oral elementary automatism is there. So that that indicate that that might be a temporal lobe epilepsy. And now we are waiting for now there is a changes, the patient is in a tonic stage, so there is a versions to the left side. So probably this is a right temporal, because version usually happens if it goes to the right, so it is a lesion in the left side. So here this is a right temporal lesion, and went for surgery, and histopathology it was denied. This is the posterior state of the patient. Again, this is the head version. So this is the characteristics of a frontal lobe seizure. It doesn't have any pre or any post-ictal phase. It suddenly appears and it goes on. So because here you see the version on the right side, so lesion in the left frontal frontal eye field. So there is a FCD in the left frontal regions. We extended up to the ventricle, so it is a transmental sign for FCDs. Again, this is a figure of 4 sign. Here the extended limb on the right side, so lesion in the left motor cortex. And again, it's a very interesting semological feature, that is ictal pouting. This is the pouting that actually we thought that this is a pseudo seizure, but after having this video, we confirmed that this is a true seizure. And usually it happens when the lesion involved with the mesial frontal regions. And we have done this surgery, and this is the post-surgical state. So second take-home message is that seizure semology, particularly aura, is important in localizing the seizure onset area. And there is just some other sign or feature is there that will help us to localize or lateralize the lesion. So how to select our cases? We get the semology. In this semology, we are seeing that patient has oral voluntary automatism, and viral arrest, so it goes in favor of temporal, and there's a head versions to the right, so it's a left temporal, might be a mid-temporal lesion, and there's a focal slowing of the left temporal chain, and this is the left temporal as well. So what I want to tell is that there is a clinical, electrical, and radiological correlation. So my take-home message is that the ideal surgical candidate are those patients who have a clinical, electrical, and radiological correlation. And there is a specific tumor, some tumor is there. We call it long-term epilepsy associated tumor. And these tumors are benign in nature. They usually presented with epilepsy. And they have a very well-defined margin, and the surgical outcome is good. And this is one of our patients that surgery has been done here. So my message is that long-term epilepsy associated tumors are different entity, and we should go for early surgical intervention. Is the surgery safe in case of epilepsy surgery? When we come to matter of safeness, so we should consider two common location. One is the motor cortex, and another is the Broca's area if it is left side. So when we have a lesion like this, a lesion involving the motor and as well as the Broca's area, we should go for wave craniotomy, because you can test in a sedated patient for speech. So this is one of the patient who presented with right-sided clonic movement repeatedly. And there is a lesion in the motor cortex on the left side, and as well as Broca's areas involved. Patient presented with expressive dysphagia. So went for motor cortex stimulation. So actually in the stimulation, we allow the patient to talk, and we stimulate the cortex, patient in awake state, and we stimulate the cortex. If any interruption in the speech, is there a speech arrest, then this is the speech area. So this is the way we actually allow the patient to speak. Now there is arrest. Now, so this is the speech area that we marked. Then we are going for motor areas. In the motor area, you are seeing that in the DTI, the fiber is displaced by the tumor itself. So this abnormal area is actually having the tumor and is displaced the motor fibers downwards. What about the sensory? Sensory, it is very interesting. I want your kind attention here. This is the central sulcus. This is the precentral gyrus for the motor. Already we stimulated this. Now we are stimulating the sensory part. In the sensory part, if we look for the representation, the part that remains lateral to the lateral sulcus or sylvian fissure, that is the tongue area. So if we stimulate this tongue area, patient will feel abnormal sensation in the tongue. So that should be the back part of the tongue. So see what the patient did here.
মানে এখানে দিলে স্যার জিহ্বা ইয়ে আছে
So,
ওখানে দিলে জিহ্বায়
so what's happening? So some feeling abnormal sensation in the back of the tongue. So that's why, in this way, we identify the sensory areas. So now, what is the result following surgery? So it's a matter of we are anxious that we injured the Broca's area. So this is the resection part. This is the following surgery. So patient can walk. We didn't do any injury in the motor cortex. Now, what about speech? Patient can't speak. So
এরকম আমি একজন
so we think that we may lose the Broca's area.
আমি
But it's
সালে
sad.
ঘুমতে উঠছি
Video after 3
পরে
weeks. Now we
ওঠার
can
পরে
speak.
আমি
So this is our second case, again involving the motor cortex. This patient got from the pediatric neurology department. The seizure started from the left upper limb, that goes to the face, and then the left lower limb. And what we're seeing, the FCD involved in the hand area. So it is very difficult for surgery, because during surgery you have to confirm that you were resecting only the hand areas, not the other part. And we first identify the central sulcus, because we have to go for the motor cortex. So this is the central sulcus, and this is the motor area. So in the motor area, which area is hand fibers? Which area are containing the hand fibers? So now we stimulated the hand area. Look to his hand. Sorry.
বলতে হবে না যখন হয় পুরো বডিটা একটা চার্জ হবে
So this area belongs to the hand area. So we are confirmed then, and again we put electrode to confirm our motor cortex for the phase reversal in the lead between 4 and 5, and this is the surgical resection. This small area can produce seizure and even causes drug resistance. And this is the posterior state of the patient. There is no motor deficit. Before surgery, her hand power was 1/5, only grip, but hand it is 4, but only grip was 1/5. So my take-home message is that resection of the lesion in the functional area can be done with satisfactory surgical outcome. So regarding the generalized seizure, the hemispherectomy is one of the common technique that you can go for. So we received a patient from the pediatric neurology department. The patient actually started his seizure that is 1.5 months age. Now he's 12 months. So from this 1.5 months, he started having this seizure. And there's epilepsy, aphasia continuous is there. There is actually initially there is the only clonic movement of the right side of the body. And seizure frequency was 12 to 15 per day. And in MRI, this is the active phase, and this is the residual phase of the Rasmussen's. What we are getting here, the whole right-sided hemisphere is involved, and there is a atrophy, hemiparesis is there. His upper limb is 1/5, lower limb was 2/5, and went for surgery for this patient. In Rasmussen's cases, we have to disconnect all. But problem is that these patients, we waited almost 3 weeks before surgery, but his chest was not too good, his nutrition condition was not too good. And so we went for stage resection. First, remove the hematoma. You see, there's a big subdural collection. This is the membrane of the subdural. It's a very thick membrane. This thick membrane itself can produce seizure. So, especially in the post-traumatic state. So we are cutting the capsule, and after resection of the capsule, now we can see the normal brain, normal gliatic atrophic brain. So in second stage, now we are going for anteriotemporal lobectomy. In anteriotemporal lobectomy, we remove everything beyond the tail of the hippocampus and anterior. This is after resection of the temporal lobe. So whole temporal lobe has been removed. Now in third stage, we are starting disconnecting the cortex. If you see this video, here we removed the whole temporal lobe. We disconnected the temporal and occipital junction. We disconnect the corpus callosum, and we disconnect the base of the frontal lobe. But because already there is a 3 to 4 hour surgery has been done, we didn't remove this cortex that we should have done this case. And this is the postoperative state of the patient. Seizure frequency decreased significantly, still though have an infrequent seizure is there. This is the histopathological report. So my take-home message is that hemispherectomy is safe because we do not do any new harm to the patient. And it is effective as well as because it significantly reduces the seizure burden. So Rumi Bhai is here. He's working for several years. He knows what is the limitation. But what we are facing now is the prolonged video EEG. Only one patient with seizure that went for surgery I have shown you. We do not have PET scan, and the cost also very important because this kind of patients, they can't afford too much. We do not have an adult neuropsychologist, and functional MRI in our institute is not available. So I think if we can overcome this kind of limitation, we can do much more better surgical outcome patient. Thank you very much.
Thank you, sir, for your brilliant presentation and showing the audiovisual presentation. And day by day, the refractory cases of epilepsy is increasing, and we hope functional neurosurgery in neuroscience will go further more and more. And now, ladies and gentlemen, now near we are end up our session.